and please feel free to interrupt me for questions, or we can break between the two lectures and have some questions. Okay? Bismillah ar-Rahman ar-Rahim. So when I think of left ventricular outflow tract obstruction, it's really a spectrum of a disease. It's not an isolated entity, as you all know. It could be just an isolated valve obstruction due to dysplasia of the valve or underdevelopment. The valve could be tricuspid and stenotic. It could be bicuspid or unicuspid and stenotic. There could be the level of obstruction could be at the supravalvular level, either in the wall of the aorta, such as the cases of Williams with supra AS, or it could be a discrete membrane just at the sinotubular junction on the inside, causing the obstruction, which is less common. It can also be at the subvalvular level due to a fibromuscular ridge, or what's commonly known as SAM in the congenital world. It's different from the SAM in the adult hypertrophic obstructive world. SAM is subaortic membrane, not systolic anterior motion. And it's a term that's frequently used to describe a fibromuscular ridge under the valve. It could be a tunnel type LVOT due to either hypertrophy of the septum or presence of accessory tissue, excessive accessory tissue related to the mitral valve, or just an underdeveloped elongated LVOT. And I added hypertrophic obstructive cardiomyopathy for the sake of completion, because in one of its forms of presentation, it does present as obstruction to the left ventricle. And of course, it could be a combination of all of these or some of them. It's important when you're tackling a left ventricular outflow tract obstruction to think of associated problems, especially mitral valve pathologies. The mitral valve could be underdeveloped or abnormal in shape and function. Aortic arch hypoplasia, coarctation of the aorta or interrupted aortic arch are all forms of aortic arch obstruction that are associated with left ventricular outflow tract obstruction in some of the cases. And the most severe form of multi-level obstruction on the left side is the Shone's complex. Some people use this term loosely to indicate the presence of mitral and aortic pathologies, but the classical Shone's complex is actually more involved and more severe than that. Left ventricular underdevelopment, especially if there is an inflow obstruction. Less flow means less growth in the fetal life. And it could be associated with subendocardial ischemia and endocardial fibroelastosis. Other cardiac anomalies could present with left ventricular outflow tract obstruction, and that can change dramatically the approach to dealing with these cases, starting from a simple VSD, an AV canal, whether balanced or unbalanced, DTGA and CCTGA. These can all be associated with forms of left ventricular outflow tract obstruction, and that has to be addressed at the time of planning your management. So if you really think about left ventricular outflow tract obstruction, as I said, it forms a spectrum of a disease. In its simplest of forms, probably, or most isolated of forms, is a valvular aortic stenosis. And if you keep adding elements that could be possibly associated with the fetal in utero development of the heart and great vessels, you can end up with a narrow LVOT on top of that, an arch underdevelopment, a mitral valve stenosis or atresia, and subsequently hypoplastic left ventricle, and you end up with the full-blown syndrome of hypoplastic left heart syndrome. I think for the sake of this presentation, I'm not going to talk about LVOT associated with other cardiac problems. We will concentrate on the aortic valve, supra and sub-AS pathologies, and try to discuss some cases related to these pathologies. Now, for aortic stenosis, the timing and the presentation are really crucial in decision making. You can be presented with a newborn who's critically ill with poor function due to critical obstruction and who's prostaglandin dependent or duct dependent. The presentation can be later in life with no patent ductus, a severe form of LVOT obstruction, but somewhat compensated heart with preserved function. Another common presentation is children presenting after a previous intervention, whether a catheter-based intervention or a previous surgical intervention, and presenting in childhood requiring a repeat intervention for obstruction or mixed obstruction and insufficiency at the level of the valve. And of course, we also have to think about the associated problems. There's an arch problem or like a transposition kind of problem, then you might have to plan your treatment in a different way. I'm not going to spend too much time talking about this, but you should know that there are calculators for the adequacy of the left-sided structures in patients with critical aortic stenosis. The original score was called the Rhodes score, and this is a kind of a modification by the Congenital Heart Surgeons Society. It's available on their website, and it can be used to give you an indication whether the left side of the heart can sustain a biventricular physiology or not. And validation of this calculator is ongoing, and I expect that there will be a modification in the near future. Data presented 2 years ago showed that the predictive value of this tool is not as great as we once thought. And some of the discordantly managed patients, and by that I mean if the calculator tells you that this patient should go for a single ventricle, but some of the patients who undergo biventricular repair in spite of that end up doing well, and vice versa. So it's still a tool under revision, but it's one of the tools that are used for especially borderline cases. Okay, so I promised you last time I will show you the references for my surgical videos, and this is Victor Hirashka's toolbooks, Surgical Management of Congenital Heart Disease, a video manual. I think it's a very valuable item to be added to the collection of people interested in congenital heart disease. And I will use the same videos, or not the same videos, I will use his videos again in today's talk to discuss different cases. So let's start with the first case of neonatal AS, a 4-kilogram neonate with critical aortic stenosis. Peak gradient on echocardiogram is around 80 millimeters of mercury with preserved function. There is no arch obstruction and only mild MR. So the echo shows an abnormally looking valve, probably unicuspid, or functionally unicuspid. Turbulent flow, preserved left ventricular function, and although there's some brightness, no severe fibroelastosis. This is a surgical view. The aorta transected above the sinotubular junction and the incision into the non-coronary sinus to widen your exposure. Now, in these neonatal valves, it's important to remember that these valves are immature, and they're full of myxoid tissue, which is sometimes very tricky to handle. You can see here that it's probably a unicusp valve. I would call it a unicusp anyways. There's one true raphe and one false raphe. And you see this thick stuff. Yeah, this is the myxoid tissue on the inside surface of the valve. It's very friable. It contributes a big deal to the obstruction, but it's very tricky to handle surgically. And you can enlarge the valve orifice area by cutting into that fused raphe and removing this myxoid tissue from the inside surface of the leaflet. Mortada, please keep an eye on the time. I have a lot of videos to go through. If you guys think something is repetitive, or if I'm using my time in a if I'm taking more than I should, then just let me know, please.
Sure, sir. We have a lot of time. Don't worry.
Okay. So here, the first leaflet is shaved off, and now it's thin, and you can see into the LV, and you can see the mobility of the leaflet is better. Same is done to the other one. And again, please appreciate how slippery and difficult to handle this myxoid tissue is. Now, once that is done, you need to reassess the valve for form and function. In this case, the anterior commissure will be resuspended high enough to allow for a reasonable coaptation, but still some shaving going on here. But you can see now the anterior leaflet of the mitral valve and the LVOT in a way that was not possible before. And usually this is all that's required in these cases, and it can take them, it can do them very well for a very long time before they need anything else done in the future. So this disrupted commissure is now put together and resuspended high enough to allow for a good coaptation. Now, keep in mind that this image is very magnified, so this valve is probably like maybe 5 or 6 millimeters in diameter, the valve annulus. So one has to be very careful not to injure adjacent structures. Again, not a normal looking valve, but if it can perform with reasonable function in the first few years of life, then it will do this patient a great deal. The posterior commissure now is open slightly into the adventitia to increase the effective orifice area again. And the valve is tested with a dilator. Okay, so this is the first video for severe neonatal aortic stenosis, and it's surgical valvotomy and repair of the valve. Okay, a second form of obstruction is the subaortic fibromuscular ridge. This is the case of a 4-year-old child who has been followed up for a small subaortic fibromuscular ridge. The most recent echo shows the gradient of 45 peak and the development of new mild aortic insufficiency. Now, it's important to remember that in these patients, we don't wait for the numbers to be as bad as the guidelines suggest for aortic valvular pathology. Most of the subaortic membranes, even in the absence of new aortic insufficiency, would probably be operated on around 40 plus millimeters of mercury for peak gradient, not mean, peak gradient. And that's much lower than the indications for the valvular aortic stenosis. But it is believed that if you wait longer, then more damage will be done to the leaflets, and you might end up with irreversible valvular pathology. Whereas if you tackle this problem at this level, then you might just get rid of the problem. in most cases.
But doctor, I
Doctor?
think the patients, they will come earlier because they will feel symptoms. They will not wait till the valve get destroyed. They will be really symptomatic. This is what I know. So it's rarely to have the valve get destroyed, right?
Well, if you operate at a gradient around 40 plus, then that shouldn't make them too symptomatic unless they have something else going on. So the whole idea is that you don't want to wait for the patients to be too symptomatic. Most of these cases are picked up early in life and are followed up as asymptomatic patients. And if they don't have anything else going on, like an intracardiac problem or an arch problem, then it's not uncommon to schedule them electively once their gradients reach 35 to 40. And of course, in the presence of any new degree of aortic insufficiency, then they should probably be even operated on sooner to prevent this process of aortic valve involvement.
Yes.
Okay, let's see how long this one is. Okay, so this is a parasternal long axis view of the LVOT. You can see that arrow pointing to the fibrous or fibromuscular membrane, and you can see this trivial amount of aortic insufficiency. Looks like this patient had something else done before. I'm not sure what, but the case vignette doesn't say anything in the book. Okay, so again, start with a transverse incision in the aorta. Some people just transect the aorta. I think for this type of pathology, you don't need to do that. And this incision into the non-coronary sinus helps a great deal in exposure. The leaflets look not too bad. They're thin and pliable. It's a tricuspid valve or trileaflet valve. And in between the right and left there in the, sorry, I'll go back. If you look in this area here now, in this area, you will see the membrane once the leaflets are open. This white ring is the membrane. So now the leaflets are retracted and the membrane is identified. And sometimes it's very hard to tell where does the membrane end or begin because there is another fibrous structure, which is the anterior leaflet of the mitral valve, and it could be very closely attached to that, or it could be attached to the belly of the aortic cusps. And you have to be extremely careful when you're shaving this membrane not to perforate the aortic leaflet or the mitral leaflet. That might need some more meticulous handling, a combination of sharp and blunt dissection. This is a plaque elevator, has different names, but it's used for endarterectomy, and it's useful in this kind of pathology as well. And here you can see he's peeling it off the back of the muscular septum onto the anterior leaflet of the mitral valve. A lot of people like to take it in one piece, make for a good photo at the end, but sometimes that's not possible. You might have to cut part of it and restart in different location to remove the remainder. Here again, below the right coronary, towards the right nun, commissure. Getting very close to the membranous septum there, and this is another area that you need to be careful not to go too deep to cause heart block. Once the fibrous component is removed, it's usually helpful to resect part of the muscular septum. This is just some accessory mitral valve tissue that's attached to the septum, and it's being resected here. And the final component, the myomectomy, helps to disrupt that ring of fibromuscular ridge and reduce the chance of recurrence. It depends how much muscle is protruding into the LV. Some people just make a slit. I personally like to take a chunk off. But again, the extent depends on how much that muscular septum is protruding into the OT. I think we'll move on. Okay, so this is a case of Williams syndrome. Williams syndrome is a genetic disease that happens most commonly as a sporadic form, but there are some reports of autosomal dominant inheritance. It's due to a missing copy of the elastin gene on chromosome 7 in almost 99% of the cases. At least that's what the literature suggests. It's an 8-month-old baby presented with congestive heart failure and a known case of Williams syndrome. This is a preoperative angiogram or a cardiac cath, which really is not done that commonly, especially for this pathology. It's thought to be excessively risky to do a cardiac cath in these patients, and the risk of intra-procedural arrest is high. So in my practice, I haven't come across a case that was diagnosed by cath, but this one was, and it makes for a nice visual presentation. So you can see the aorta is entirely small, and you can see the narrowing just above the sinotubular junction. So interestingly, in this case, there is also associated pulmonary valve hypoplasia. Sorry, pulmonary artery, branch pulmonary artery stenosis diffusely. And this does happen in some cases, but not in most cases. From the outside, they don't look too bad. If you look at the PAs, you wouldn't expect that angiographic image. I mean, the RPA and LPA look reasonable in size. You can see the aortic stenosis, the supravalvular aortic stenosis. Well, the hallmark of this disease is how thick the walls are, and you'll see in a second here how thick these walls are. So this is the aorta transected, and look at that. You can hardly see the anatomy. You can see an excessively thick aortic wall. And the first thing to do is to identify where the non-coronary sinus is and open the aortic root into the coronary sinus, into the non-coronary sinus. And that will help open up the root, and you can examine things a lot easier once that is done. So you can see here, once you start getting into the root, the aortic wall becomes thin again, and you can see the leaflets now. It looks like the non-coronary is the biggest leaflet, followed by the right, and then the smallest is the left. There are different ways of repairing this pathology. There's a single patch technique, a double patch technique, and a 3-patch technique. Basically, the number is related to the number of incisions you make into the aortic root. And probing the coronary to identify the anatomy more. And of course, here you have to be careful not to encroach on the too much. And really, you don't have to go deep. You don't have to go to the annulus. Once the root opens up and you start seeing healthy aortic tissue, you can stop there. This is just an example of a supravalvular membrane that's associated with this pathology. And then this teardrop shaped patch used to reconstruct each sinus separately.
This is the 3-patch technique, right?
This is a 3-patch technique, yes.
This technique gives you a better geometry for the for the sinuses, right?
Yeah, my personal opinion, I agree, but I don't think the evidence, there is any evidence to prove a superior results with the 3 versus the 2 patch technique. There has been some papers written on that, and people have different preferences in the community. But yeah, personally, if I can do a 3 patch technique, I would do it. The only word of caution I would suggest is evaluating that left coronary sinus very well. And if you think you're going to be risking the left coronary artery, then probably avoid doing the patch in that sinus. But if there is space to allow for it, then it's probably better.
Dr. Muhammad, you are using the same technique with same material, or you are using the pericardial patch?
I personally use bovine pericardium. And in all honesty, I don't paper my patches like a triangle at the bottom. I make them a little bit wider. But as I think the point here is that the pathology is not really deep into the root. It's almost at the sinotubular junction. So if you incise past that thick area, then you don't have to do much enlargement in the root itself.
And the indications for surgery is the same as the subvalvular type. Is that right?
Well,
in terms of symptoms and the gradient.
Yeah, I'm not sure there are. The presentation of these babies is a lot more dramatic than subaortic membrane. These patients are sicker and are sicker at an earlier stage. So yeah, usually they have thick ventricles and higher gradients. I'm not sure there is a number in terms of guidelines just for peak gradient in this pathology or specific to this pathology, but one can, I would probably expect that most of these patients at the time of the operation, they have much higher gradients than 40 and 45. So this is the final, you can see the anterior patch has been left long to enlarge the area. This is the pulmonary artery component. Well, I guess it's kind of interesting to watch, so I'm just going to leave it running. Again, look at the thickness of this thing. From the outside, it looks okay, but it's a hair-like lumen, very thin. And I guess you can call this kind of a hilum to hilum enlargement. Okay, let me just skip the PA part. Autologous pericardial patch for the PAs. And now this is the ascending aorta being enlarged. If you remember how the cath looked, this is a diffuse pathology, and it's really almost impossible to restore the entire aorta to a normal diameter. And these patients might need some future interventions.
And what about those 3 patches? They are not going to grow with the patient. So those patients usually need further intervention?
The thought is the tissue in between will grow. I did not have to reoperate on a supra AS patient that I did yet, but again, I'm relatively young into this career. I mean, probably do 2 to 3 of these cases a year. It's not very common, and so far, none of them needed a re-intervention for the aortic root. Actually, this year with the whole COVID situation since March, we haven't had a single case of super AS. So it's really not that common. Okay, let's move on. Are the videos clear?
Yes, clear.
Okay. This is an example of a patient who underwent a catheter balloon valvuloplasty as a neonate, and it served him well for 9 years, and now presented mainly with an aortic insufficiency problem with moderate aortic stenosis. And the underlying pathology is believed to be a unicuspid aortic valve. So this is another example of an aortic valve repair, but it will use a different technique. I'll show you in a minute. So predominantly regurgitant valve, not mixed type pathology. Now, it's not a redo. You see the irregular tear there of the leaflet off the annulus and in the right side. So the balloon really just opened that area irregularly, leading to the progressive regurgitation. So what would try is this valve. So move this part of the leaflet. Otherwise it's a mobile leaflet of a good size. So to create a commissure, and that will end up resulting in one missing cusp. And that cusp will then be reconstructed out of autologous pericardium. So the raphe is mobilized and reattached. This is now the non-coronary cusp. And this is called tricuspidization of a well, functionally bicuspid valve. So that free margin is now reattached to the wall to create a commissure. Of course, tricuspidization is not a very specific term. You can tricuspidize a bicuspid valve, or you can tricuspidize a quadricuspid valve, but I think you get the idea here. So he's trying to turn a bicuspid / unicuspid valve into a tri-leaflet or a tricuspid valve. Same thing here, creating the new commissure between the left and right. Even though this is considered a form of valve repair, I think of it as a 1/3 replacement, because this third leaflet is going to be made of pericardium. And data on pericardium reconstruction of the aortic valve in children has been around since the 80s. And it's a good solution with good midterm results, but a lot of these patients on the long term come back requiring something done due to calcification of the pericardium and adjacent structures. So now this is a generous patch of pericardium, and it's going to be used to fill that defect in the right coronary sinus to create a right coronary cusp. This is the annular part. And it's, in a way, it's very similar to the Ozaki technique, but the Ozaki uses pre-measured molds for the aortic leaflets, and it replaces all 3 leaflets. So it's a form of a valve replacement. Now, the commissure between right and left reinforced for the right leaflet, or for the pericardial leaflet. And it's important to get the height right. If you have to err, just make it a little bit higher than what you think is needed. don't make it lower, and that should improve coaptation, hopefully. Same thing between the right and the none. If you watch enough videos and read enough literature, there are multiple ways of reconstructing an aortic valve with a piece of pericardium, be it autologous or animal pericardium, using 3 separate pieces, using a cylinder. And people try to be innovative, especially in younger kids, because there are no great options for replacement in terms of manufactured valves. Of course, the Ross operation is an option in these kids, and we will touch on that in a few minutes. So just resuspending the commissures to make sure there is no big gaps between the leaflets, and you end up with a tri-leaflet valve that's both competent and not stenotic. Okay. So far we've covered neonatal AS, recurrent pathology after intervention, subaortic and supraaortic pathologies. This is a different case of a child who presents with mixed aortic stenosis and aortic insufficiency after an attempted bicuspid valve surgical valvotomy previously, and been followed up for a few years, and now presents with a mixed type pathology. And the decision was to proceed with the aortic valve replacement using a pulmonary autograft, or what's known as the Ross operation. So, sorry. So in this case, there is no, the pathology is isolated to the aortic valve, no subaortic problem. There's no size mismatch really between the aorta and the PA, and the LV function is normal. You can see the dysfunctional valve with very limited mobility and severe insufficiency. Sorry. Okay. This patient looks like had an arch repair in the previous operation as well. The left coronary button here is mobilized after transecting the aorta, and you can see the faulty leaflets already very thickened and calcified. The coronary mobilization is very similar to what you do in a Bentel procedure or a switch operation. You have to do it very carefully and mobilize enough to be able to reimplant this button with no undue tension or distortion. The right button is mobilized.
دكتور محمد؟
بدي يوقف ولا أنا من عندي؟
لا وقف على الجميع. دكتور محمد؟ الظاهر من عند الدكتور. شوي بس خليني أتصل عليه.
Am I still on? Can you hear me?
دكتور البرزنتيشن حقك وقف وبعدها خلاص ما عاد في sharing.
Okay.
We don't see your presentation.
Yalla, I'm gonna reshare my screen. How about now?
Yes,
How
we
about
can
now?
see it. Yeah.
Okay. Sorry, I'm using my phone as a hotspot, and when I get a call, it gets interrupted. Okay, so the leaflets were excised after mobilizing the buttons. Now the pulmonary artery is transected just below the bifurcation, and the explantation of the autograft is begun on the infundibulum of the RV. It's very important to be thoughtful of the positions of the coronaries and the pulmonary leaflets when this is done. So it's done with extreme care, not to injure any coronary branches, especially the left main and the first septal. And you see how close the pulmonary valve leaflets are to the incision. If you look here, this is the inflow part of the septum, or the muscle of Lancisi, which is the tricuspid attachment. You definitely don't want to go below that when you're dissecting. So you just need a skirt of 2 to 3 millimeters under the valve leaflets to be able to sew to, not much more than that, especially if you're not doing a cono component to the operation. In this case, they could see the septal. I don't look for it. I really don't look for it. As you can see, there are two separate layers. So if you stay shallow in your septal incision there, you should be fine and away from the first septal perforator. A combination of sharp and cautery dissection. Now, because of the advances made in the aortic valve repair techniques, most of the Ross procedures end up being redo procedures. And that adds a component of difficulty to the dissection. But if you follow anatomical boundaries and be careful, it should be fine. The valve inspection is done to make sure there are no damage to the leaflets or to the sinuses. This is just additional dosing of cardioplegia. As you can see, the annulus here is preserved. There is no conal incision, and we'll show that in the next case, because there is no subvalvular pathology. The LVOT is wide open. It's just an isolated aortic valve pathology. And the autograft is sewn in place with a running protein. People do this part differently. Some people use pledgeted sutures. Some people use simple interrupted proline sutures. I personally use a running technique, but I reinforce the septal area with pledgeted sutures. Some people implant this in a Dacron graft, especially in older kids and adults, to prevent root dilatation, and then implant sort of a composite autograft in a Dacron tube. I will not show this procedure. It's known as the Ungerleider modification, and it's available online as publications, open access publications, and as videos as well. The LVOT is inspected and found adequate.
Dr. Muhammad?
Aywa.
Kindly, I didn't get the part of using Dacron graft to prevent sinuses dilatation or annular dilatation. Could you kindly elaborate more on that? I didn't get it.
one of the modifications that has been introduced, I think it was around 2008, 2007, by the group in Portland at the time, Ross Ungerleider, devised a way to implant the autograft in a Dacron tube, similar to, it looks like a David reimplantation end product, but instead of implanting the patient's native aortic root, you implant the autograft and then implant it like a bental. It is meant to prevent root dilatation over time, because this is one of the problems with the Ross operation, is that you end up getting some degree of root dilatation. So the thought is, if you fix it in a Dacron tube, it will not dilate with time. And it has been gaining popularity over the last decade. And I think for people who do a lot of Ross operations in adult patients, it can be handy to do it that way.
I see. Yani you're creating a tongue like Yaqub, or just like in the annulus, you create a ring?
No, you reimplant the whole autograft in a tube of Dacron with two suture lines, one proximal and one distal. I can probably send you on the group one of the publications, on the WhatsApp group, one of the publications after the session.
Okay, okay. That would be great. Thank you very much.
No problem. So the coronary buttons are reimplanted, similar to a Bental procedure. And then the autograft is now anastomosed to the ascending aorta. And a lot of people do this, so even in arterial switches, they complete the root and pressurize it to decide on the position of the right coronary button. I personally don't. I usually do the posterior wall of the aorta and then reimplant the coronaries. But it's not a bad idea. It helps with judgment. And looks like he used a trapdoor technique here to prevent any tension on the button. So this part is really similar to the left coronary. And then the RV to PA continuity is restored with a conduit, with a valve conduit. We personally don't have access to homografts here in my hospital, so we use the bovine jugular vein conduit with Integra, but it's very similar. You start with the distal end anastomosis between the conduit and the bifurcation. Like I was saying, you know, my generation of trainees had been exposed to a variety of aortic valve repair techniques. And really, we don't do that many Rosses as a primary operation. And you end up having to do a Ross probably as a second or a third redo sometimes. Last week, I had to do one as a third redo on a 7-year-old girl who had 2 attempts of subaortic membrane resection and aortic valve repair, but still had significant LVOT obstruction and was starting to have moderate plus AI. So she ended up getting a Ross cono as a surgery operation. And I think this will be the norm for your generation of surgeons as well. I mean, I'm not that much older than you guys, and people try to repair valves more and more. That applies to the aortic valve as well. And you can still see centers where a primary Ross operation is a popular option, but that's not the international trend anymore. I think it's an extremely valuable operation, and some patients will most definitely need it, but I don't think the prevalence will be high. Okay, as opposed to that last case, this case, you can see the discrepancy between the pulmonary root and the aorta, and it's almost 3 times the size, and that's because the aorta and subaortic area is somewhat hypoplastic. And this case will be a Ross Cono operation to address the valvular and subvalvular areas. Similar dissection. Again, I think this patient had an aortic valve repair in the case scenario that's in the book. So you can see it's a redo case again. You can just see the size discrepancy here between the 2 roots, at least 3 times the size of the aorta. The pulmonary root could be a little bit dilated, but the aortic root is definitely small. Coronaries are mobilized. You can see the repair sutures on the valve. I don't know if they use some leaflet extension techniques in the previous surgery here. Left coronary mobilized. I'm not going to play this entire video. I'm just going to show you the cono component because the rest is very similar to the previous one. The right coronary. You can see the suture lines from the previous aortotomy. Once that's dissected, the root is wide open. And if you're committed to doing a Ross operation, then you start by taking the leaflets out. And that will show you the pathology underneath. Calcified thick leaflets, looks like there's some extension from a previous surgery. Once that is removed, so you can appreciate that the LVOT here is much smaller if you compare it to the right ventricle, and just replacing the valve at the leaflet position is not going to be adequate to address the pathology. So autograft again is harvested. I can skip this part. Yes.
So is it a good idea to take this pulmonary valve since it's look dilated pulmonary, or it's the aorta which is small?
Yeah, this is an 8-month-old baby. So if you think about the options you have, you really don't have that many for replacement. So we can do an Ozaki for the leaflets, for example, but it's not going to address the subvalvular area. You can think of doing a cono type repair, but again, I doubt you'll be able to get the smallest prosthesis with a cono mechanical, say, kind of repair. So I think in this type of pathology, you can use a dilated pulmonary root, and you'll see how. We'll see how now in a minute. Okay. As long as the valve is competent, the pulmonary root is functional, yeah, it can work. In this area, I think he's approximating the part of the septum with the epicardial fat. Not sure why, maybe to control some of the bleeders. You can see some cardioplegia there, so maybe there is like a side branch bleeder or something. Okay, now pay attention to this part. So to the left of the left and right commissure, extend the incision through the annulus onto the septum. And you can see this whitish area. This is not the mitral valve. This is on the septum. This is what we call fibrous endocardial fibroelastosis, sorry. And this is the cono incision, and it will be made larger as the video proceeds to accommodate the larger autograft. This is the endocardial fibroelastosis. It can be very thick and very extensive. It can go all the way around the papillary muscles and to the apex of the heart. And a lot of people believe that if you remove a significant chunk of it, it can improve the restrictive pathophysiology of the left ventricle. Looks like they're going deep into the ventricle in this case. Sorry, I haven't seen these videos in a while, so I'm kind of reminding myself about the details of them. And this is, you see, this is quite an impressive piece of membrane, which was shaved off the muscle. And you can see the papillaries here, they're white and shiny. This is also endocardial fibroelastosis. But anyway, so they removed a big part of it, but not all of it. I guess it's not possible to remove all of it in some cases. Now, assessing the valve. So if you're doing a cono, you want to take a slightly longer skirt of muscle under the pulmonary valve, and you'll use that to close the VSD. Some additional resection here and additional myotomy, I guess. This is just enlarging the cono incision into the septum. And I'll show you how this looks once it's sitting in position. Here you're coming to the septal part, or the muscular part of the anastomosis. And as you can see, if you incise the septum, you can make the aortic annulus as big as you want, really. But, you know, you don't want to do an excessive incision, not to affect the function of the ventricle or the conduction system. But as you can see here now, the conduit is sitting in place in spite of that huge size discrepancy. And these are just reinforcing sutures, budgeted sutures on the muscular part. And this is a second layer of adventitial reinforcement for hemostatic effects, really not for anything else. So just the remnant of the aortic root, or whatever's left of it, to the opposing part of the autograft. Okay, let's see here. Coronary implantation. Like I said, these presentations are available for you guys. We just have to find a way that I can send them to you. So let me know. You're better at these things than I am.
I will let maybe Dr. Abdul Malik, I will discuss with him, then he can contact you, Dr. Muhammad.
Excellent, excellent. Okay, this is the, looks like the pulmonary homograph now being used to complete the final part of the procedure, which is restoring the RV to PA continuity. Okay, I think this concludes the first part of the presentation. I'm not sure what time is it. What time is it, guys? So we're 8 minutes into the second talk, but I started late, so we can take maybe some questions. Hello?
Yes, with you, Dr. Muhammad.
Okay. If there are no questions, maybe just take a 1 or 2 minute break to drink water or move around or something, and then come back and we can start the second part.
Regarding growth in adult, Dr. Muhammad, what do you think the future of the ROS, especially in adult population? From what I read, it's usually need an experienced surgeon to do that, to do ROS. But any specific indication for in adult population? For example, in cases with aortic stenosis or aortic regurg, those kind of patients, if they want to, especially the female, if they want to avoid a complication either of mechanical or bioprosthesis. There is a lot of literature about this talk. I actually watch a lot, but at the end, on the beginning of those presentation, they emphasize on the experience and all that. If you can elaborate more about this topic, especially for us and for us, for those who want to seek this specialty, what path they have to go through.
Yes, that's a very important point. And if you look at the agenda of most recent surgical symposia or aortic symposia, you'll find this subject for debate in most of them. And the reason is the modern literature has not been kind to the Ross operation, I must say. The Ross operation is a technically complex operation. It definitely needs a lot of exposure during the training. And it's not the kind of procedure you want to take on in your first years of practice alone. However, there is some very robust data, even in adult population, that the Ross operation probably has the most superior survival curve if you compare it to any other prosthesis out there. And there has been a randomized trial by the Magdi Yacoub group. It was I think Ismail Al-Hamamsi from Montreal. Now he's in Montreal. At that time, he was with Magdi Yacoub. He's the first author, and it's a very well-designed trial. And if you look at the German and the Dutch registries for the Ross procedure, you'll find the survival curves are quite superior. Now, the reintervention curves are what's always brought in question, and how many times you have to re-intervene on the autograft or the RV2PA conduit. Now, it's not an insignificant thing. I guess a first time RV2PA conduit replacement is not a problem, but a second and a third and a fourth, that could carry excessive risk. And although we think of the Ross as a lifelong treatment for the aortic position, it's not entirely true in all cases. There is a small but significant percentage of patients that will have a Ross and end up having a mechanical valve or some sort of a root procedure, which really defies the purpose of doing the Ross at the first place. I'm not sure if this answer helps, but for you, if you think you want to incorporate the Ross operation into your practice, you will be belonging to the minority group of surgeons, and you have to follow a very specific pathway during your training. You have to go to a place that does these cases every week or twice a month in order to have enough exposure, or you should probably practice in a place that offers these operations and have some senior mentors with you when you're starting off. It's not an impossible procedure to do. Like anything complex, once you understand the basic components and you do it a few times, it becomes not very complex. I do think the Ross procedure will continue to have a role, both in pediatric and in adult patients. Its role in adult patients is getting less obvious. However, I think until we find a perfect anticoagulant, which is what I've been told since I was a medical student, in few years, we will find the perfect anticoagulant that will need no monitoring, no dose adjustments, and will have no complications. And guess what? 20 years later, well, not 20, 15 years later, we still haven't found that perfect anticoagulant for mechanical valves. And I don't think we'll find it anytime soon. Until that day comes, I think the Ross operation will have its role in the adult world, especially like you said, in young ladies who wish to avoid anticoagulation for a variety of reasons. I heard senior surgeons asked if you had to undergo aortic valve replacement for aortic stenosis, what would you what would your option or your best option be, and they chose the Ross operation in experienced hands. And that tells you that although most of the community is against it, some people still believe it has a value. I mean, I wouldn't recommend it for someone who's 60 plus, but maybe if you're 50 or 55 and you don't want to use anticoagulation and you're otherwise healthy, you know, might not be a bad option in experienced hands. So yeah, that's a long answer for a short question, and I don't think it answers all aspects, but it's currently my thoughts on the subject. I personally don't do it in adults. I only do it in kids, but never say never, I guess.
And regarding the fellowship, is it like the one has to go for aortic fellowship and concentrate with the one senior, or I have to go, for example, or the one who want to pursue this specialty for pediatric, then he can do adult and pediatric?
There's a lot of large pediatric centers that don't do Ross operations or do very little Ross operations. I think if your interest is the Ross operation, maybe towards the end of your fellowship or in the second year of your fellowship, you should get in touch with someone who does a lot of them and just go spend some time with them. We happen to have a national treasure when it comes to the Ross operation. And he can probably, Dr. Al-Halis can probably be more helpful in pointing you in the direction of other places that do the Ross operation and have well-established training for it. Yeah, I know this guy, what's his name, Ismail Al-Hamamsi. He's originally Egyptian. He's in Montreal, the French part of Montreal. And I think he does like 100 a year or something, something ridiculous, like not 100 a year, but he's like 7 years into practice and he has over 500 Rosses. So he does a lot of them, and maybe he's worth getting in touch with. New York, the Paul Stelter group, which I think, by the way, Ismail Al-Hamamsi moved to New York now that I'm thinking about it, to replace Paul Stelzer. Paul Stelzer was one of the senior surgeons who did Rosses, and I think they just recruited Ismail last year to be his replacement. So he's in New York now, just before the whole COVID situation started. Mount Sinai Hospital in New York. Yeah, that's one of the places that I can think of for adult, a large volume of adult Ross. And there are many European centers that offer it, but I really have no experience when it comes to the European centers. But I mean, we can discuss that later.
Okay,
and I'm sure there are people that are more helpful than me in that regard.
Thank you very much.
Okay.
Dr. Mohammed?
Yes.
I just want to clarify one point regarding the indication for surgery for patient with subaortic stenosis, because I remember you said usually they are indicated if they have a peak gradient of 40 to 45.
Some people even say 50.
Because I remember when I read the recommendation for intervention, and this is just for clarification for myself and for others maybe. I remember they categorized them as two groups: symptomatic patients and asymptomatic patients. For asymptomatic patients, they usually do them with a peak gradient of more than 50. And for symptomatic patients, in terms of arrhythmias, congestive heart failure, or any kind of other symptoms or ECG changes, for those patients, they usually do them with a peak gradient of more than 30, or electively if they are going for surgery for other procedures. What do you think of those recommendations?
I'm not sure about the reference you're quoting. I can tell you will see variability in different references. I generally agree with what you said, but it's really hard to imagine that someone with a gradient of 40 will be terribly symptomatic or have arrhythmias from an isolated membrane. There has to be something else going on. If you're concerned about protecting the aortic valve for the long term, I guess new onset AI is a key factor in deciding to operate early or not, regardless of the gradient. But yeah, I mean, these numbers sound reasonable. For the sake of the exam, it's not going to be very confusing. Like I'm not, the options won't be 35, 40, or 45. It's not going to be like that. So don't worry. It will be a clear-cut indication. I'm not aware of a pediatric guidelines, clear pediatric guidelines for the subaortic fibromuscular ridge, but I might be outdated in reading. And if there is anything recent that's been published, please share it on the group and we can all learn from it.
Okay, I'll share it today.
Okay, thank you.
Thank you.
Okay, so can we move on with the second part?
Yes, please.
So at the more severe form of the spectrum, there is hypoplastic left heart syndrome and its variants. And hypoplastic left heart syndrome is in a way, is a multi-level obstruction of the left side. But the hallmark is that the left side cannot be used to maintain systemic circulation, no matter what you do. Even if you fix the aortic valve or the mitral valve or the arch, you cannot use the left side to support the systemic circulation. The anatomical variants for hypoplastic left heart syndrome, it can be a combination of mitral stenosis, aortic stenosis, with a small ventricle and aortic hypoplasia. It could be mitral stenosis and aortic atresia. And this was thought to be historically a higher risk category because of the development of myocardial sinusoids. But I mean, that has changed recently, but you can consider it a high risk category for hypoplastic left heart syndrome. Mitral atresia and aortic atresia, and mitral atresia and aortic stenosis. So these are all different combinations of aortic and mitral pathologies in hypoplastic left heart syndrome. In contemporary series, the importance of the anatomical variant of aortic and mitral pathology has become less important on the outcome of intervention for hypoplastic left heart syndrome. But historically, if you had to choose like a highest risk group, I would say it's the mitral stenosis, aortic atresia, and maybe in the question segment we can elaborate more on that. A double-ended left ventricle with transposed great arteries and coarctation or interruption or hypoplasia, again, is a variant where the aorta comes out of a small right ventricle and the true systematic outflow is a VSD. And quite often in these cases, you have to do some sort of a Norwood operation to palliate them. Tricuspid atresia TGA coarctation, again, is very similar to double-ended LV with that combination. So you can add to that unbalanced forms of AV canal and isomeric hearts associated with coarctation, where you have a hypoplastic left ventricle in an unbalanced canal with aortic hypoplasia or arch hypoplasia. These are really the forms of anatomical variants of hypoplastic left heart syndrome. So as you can see, it's not just a single entity. It's a variety of combinations that leads to the same pathophysiology, so to speak. However, there are people who first developed interest into this entity and try to identify it as a separate entity. Maurice Lev from Chicago had very early descriptions of hypoplastic aortic tract complex, he called it. And soon after that, Noonan and Nadas coined the term hypoplastic left heart syndrome in 1958. Center for these cases, you'll probably see between 30 to 40 referrals per year. Some of them won't be fit for surgery. Most of the busy centers in the kingdom that offer the surgery do around 20 to 25 cases a year, I would say. There are not that many centers that do these cases. That's why probably the majority of the cases are only being sent at the current time to two or three centers in the kingdom. Even though it's relatively uncommon, it accounts for a high percentage of cardiac deaths on the waiting list for congenital heart disease, and that's an important factor. That's why it's commonly a subject of debate in meetings, and people are trying to improve the delays and the waiting times for transfer of these patients. Without surgical palliation, it's almost universally fatal. Most patients die within the first month of life, and there is a male predominance that's observed in this diagnosis. So basically, the RV perfuses both pulmonary and systemic circulation. It's a ductal-dependent systemic circulation type of pathology. The atrial defect is important for mixing and decompressing the pulmonary veins. And as long as the pulmonary vascular resistance is close to the systemic circulation or to the systemic vascular resistance, the circulation is balanced. Once the PVR starts dropping, the baby starts getting into trouble. So the presentation depends on the adequacy of the systemic perfusion. The duct has to be patent, pulmonary vascular resistance has to be high, and the size of the interatrial communication has to be adequate. And like we said, without an operation, most of these kids die in the first month. Bill Norwood, or William Norwood, has been working on this in Boston with a group of surgeons and came up with the initial description of the Norwood operation as a first stage palliation for this pathology. And really, when I had the chance of meeting Bill Norwood and listening to him, and his thought was that univentricular repairs or palliations are being offered to other forms of univentricular hearts with the right dominant ventricle. So why not apply the same principles to hypoplastic left heart syndrome? Of course, there was a lot of failures in the beginning, and it's a really polarizing subject when it comes to the community, congenital heart disease, especially like in our part of the world, where you have people who are strongly against it and others who are strong advocates of it, like myself. I don't think it's a right or wrong kind of question. It really depends on so many things. The operation is one thing, but the support system around the operation is of paramount importance. And if that's not adequate, the operation will probably not have a good outcome, even if it led to early survival. One thing worth mentioning is that the original shunt for the pulmonary blood supply that was described by Norwood, as you can see in the bottom right corner, it was a central shunt. It was not a VT shunt, and it was not a Sano shunt or an RV to PA shunt. It was a central shunt that was described in the first report in '83. After that, the operation has evolved into arch and aortic reconstruction, atrial septectomy, and providing a source for pulmonary blood flow. And if you look at the STS database, it's almost divided 50-50 between a BT shunt and a Sano shunt. However, if you take the more recent reports, probably the Sano shunt is becoming more predominantly used. An alternative approach to the first stage palliation is a hybrid approach as opposed to undergoing a major surgery. Combination of ductal stenting and surgical peripheral bands plus minus balloon septostomy can be used as a temporizing measure to avoid the big operation at the neonatal period. However, you're just delaying it to a later stage. So the second operation, instead of being a Glenn shunt in the Norwood population, if the patient had a hybrid stage 1, then the bigger operation will be the comprehensive Norwood Glenn operation at the stage 2. They will be a little bit older and probably can tolerate the big operation better. That's kind of the argument. But yeah, that's still debatable, I guess. Okay, so the first video will be a Norwood BT shunt. And I just want you to pay attention to the size discrepancy between the aorta, ascending aorta, and aortic root, which quite often in these cases is less than 2 millimeters, and the pulmonary root. And I will walk you through the video step by step. Again, no one is going to ask you to describe this video in details on the exam, at least the residency exam. And I think it's more for like education purposes rather than exams purposes. Echocardiogram shows a very tiny left ventricle. Yeah, not sure what this. Anyways, this is the. You can see the pulmonary valve. This is the aortic valve. A small circle here is the aortic valve and ascending aorta. Again, this hair-like structure is the ascending aorta. It's very tiny in these cases. In the hypoplastic variants, the ascending aorta tends to be bigger. Okay, so if you can pay it, you probably miss it as a fibrous band if you're not familiar with the anatomy in these cases. It's very tiny ascending aorta. And the whole concept of the Norwood operation is to incorporate that into the pulmonary root and reconstruct that with the artery repair to provide systemic circulation and then provide a source of pulmonary blood flow. Like in any ductal dependent circulation, prior to going on pump, you have to control the branch pulmonary arteries to prevent lung flooding. In this procedure, he's using the innominate artery, sewing what will be the future BT shunt. I think he's going to use it for the arterial part of the cardiopulmonary bypass. So this is just probably a 3.5 millimeter shunt that's anastomosed to the innominate artery. And you can put the arterial cannula in it. It allows for cardiopulmonary bypass, and it also allows for selective cerebral perfusion during the arch reconstruction. Probably too technical of a point. If you're going to use this graft after the heart, after coming off pump to reconstruct the BT shunt, then it has to be sewn to the outer surface of the innominate artery. I usually do Sano shunts, but I still use this graft for cerebral perfusion, and I sew it to the upper surface of the innominate artery. It's just a technical point. Now the duct is divided, the descending aorta is mobilized. You can see the arch is not terribly hypoplastic, but the ascending aorta is just too small. Okay, this is a modification that I'm not going to bother you with. This is just a descending aortic cannula under the heart to maintain full body perfusion. The pulmonary bifurcation is augmented with a patch to avoid any stenosis at the origin of the branch PAs. Okay, all ductal tissue now is excised. The hypoplastic aorta is incised. take back incision to the descending aorta is performed. And the ascending aorta is incised all the way down to the sinotubular junction. As you can imagine, this hypoplastic ascending aorta will basically serve as a coronary artery in the future. It's just a source of coronary blood flow. There is no valve or a dysfunctional valve at the end of this. And the only purpose of incorporating it in the anastomosis is for coronary perfusion. So one has to be careful not to twist or kink this hypoplastic ascending aorta. Now it's being anastomosed to the pulmonary root, which will be the neo-aortic root. And this is known as the DKS component, or the Damas K Stenzel component of the operation. This is the descending aorta, now being reconstructed and enlarged with a patch. I believe this is a pulmonary homograft patch, just like part of the wall of the pulmonary artery. And it's used to enlarge the rest of the aorta, and then it will be incorporated into that neo-aortic root. And that constructs the aortic reconstruction part of the Norwood operation. Let's just move a little bit faster here. Okay. The patch is trimmed. Now the ascending hypoplastic ascending aorta is incorporated into the patch enlargement. Now the neo-aortic root, or the pulmonary root, is incorporated. So once that is completed, you can see now this neo-aorta consists of the pulmonary root, the hypoplastic aorta, and the aortic arch with this large patch reconstruction. Once the patient, the cannula is shifted now to the neo-aorta, the aortic cannula, and the shunt is shortened and anastomosed to the RPA for the BT shunt component of the procedure. And that's the Norwood BT operation. Okay. The Norwood Sano, I'm just going to show you the Sano component, where pulmonary blood supply is provided by RV to PA continuity. Again, it's a hypoplastic left heart. You can see the ascending aorta is tiny. Branch pulmonary arteries are controlled. This is the, I believe, the Sano part. Let me just go back. Yeah, so a Gortex tube, again, similar to the BT shunt, but usually larger in size. For an average neonate, it's probably a size 5 or 6 for a Sano shunt, as opposed to a 3.5 to 4 for a BT. That's in millimeters. Now this beveled part is anastomosed to the bifurcation of the PAs. And at the end of the case, it will be anastomosed to the RVOT. Probably show you the end part. This is the aortic reconstruction. Again, the same thing, aortic reconstruction. Here, this is the infundibulotomy. You want to make sure that there are no muscle bundles obstructing blood flow underneath the ventriculotomy. And then the graft is shortened and anastomosed to the RV. It is believed that an RV to be a conduit provides less coronary steal and less pulmonary overcirculation. But there is the expense of doing a ventriculotomy. So the short-term data suggests superiority of the Sano shunt in survival, but the difference is not that big. Okay. Just an interesting concept before my battery dies. I wrote this paper when I was in my fellowship about staged biventricular repair. These are patients who present with some sort of hypoplast variant with a VSD or complex LVOT with arch obstruction. And you cannot make a clear decision of which way to go when they're neonates. So they undergo an Norwood operation as neonates, but then upon follow-up, they're believed to be suitable for conversion to biventricular circulation. It's called the staged Norwood-Rastelli approach. A one-stage operation for this kind of pathology in more clear-cut cases is called a Yasui operation. I'm not going to bother you with these details. It's really kind of fellowship level, but I'll just show you a quick video of a conversion of a Norwood Sano to a biventricular repair where the Sano shunt is removed, the VSD is closed.
Maybe Dr. Muhammad, his battery is dead already.
مرتضى
هلا والله.
خلص محمد قطع النت عنده خلاص ولا كيف؟
والله ما ادري، يبغى لي اتواصل معه عشان اتاكد.
هو يقول بطاريته بتخلص قبل
دقيقه
شوي،
قاعد.
شكله
لا
قطع معه.
لحظه يكلمني. لا شباب، دكتور محمد بيرجع شوي بس بيشحن بيحط اللابتوب بالشاحن بيرجع له.
تمام.
Assalamu alaikum.
عليكم السلام ورحمة
Hello?
الله. تفضل دكتور.
Can you hear me all?
Yep.
Okay, sorry, my laptop died. I had to plug it in the charger. So this is a patient who underwent a Norwood Sano operation because the size of the left ventricle was thought to be too small for biventricular repair. And with time, the LV grew, and now the patient is believed to be suitable for a biventricular repair. Now, of course, you have to have a VSD in order to do this operation. And the first operation was similar to the Norwood Sano. This is the Sano shunt. It's excised. And I'm just going to show you quickly. Here, the PAs are dissected just to make it easier for the RV to be a conduit implantation. And then I'll show you. Now, this is the ventricular end of the Sano shunt being removed. And through that, one can assess the VSD. Sometimes it needs to be enlarged. And then the VSD is closed in a way so that the blood will flow from the left ventricle through the VSD into the DKS, and that will be the left ventricular outflow tract. And then an RV to PA conduit is inserted at this ventriculotomy. This is just enlargement of the VSD, is to make sure that the left ventricular outflow is not compromised. And I'll show you here. Yeah, these are just interrupted sutures all around the VSD in such a way that the blood will flow through the VSD into the DKS, which was done in the previous operation, because still the negative valve is too small to be used. So you can think of it as an LVOT bypass or an aortic valve bypass technique, really. And finally, a valve conduit, in this case, a jugular, bovine jugular vein graft or a Integra, is anastomosed to the bifurcation. And lastly, to the ventriculotomy. And this converts a first stage palliative single ventricle repair into a more definitive biventricular repair. So this is just to emphasize the need for ongoing assessment of these patients. Just because they underwent an initial procedure as neonates doesn't mean that the rest of their future is dictated and finalized. There is room for revising decisions and changing strategies depending on how the patient characteristics change. I hope this wasn't too heavy for you guys. And I know it's a very complex if we want to get into each and every detail, but this is just an overview of the spectrum of left ventricular outflow tract obstruction and principles in the management of hypoplastic left heart syndrome. And I think we can use whatever's left of the time for a few questions if you have any. And again, these presentations are set aside in my laptop. As soon as we find a way to send them to you, I will share them hopefully with all the videos embedded. And I put the reference for the videos today. So if you guys want to go further and get these references, it's entirely up to you. It has nothing to do with the curriculum or the exam. I think they're just very rich educational material, especially for people interested in congenital heart disease.
Dr. Muhammad? The RV to BA conduit is called also Sano shunt?
Yes, that's a very good question. Yes, it's called the Sano shunt after Shunji Sano, a surgeon from Japan who revived this. There are other surgeons that claim that they described it before Shunji Sano, but yeah, it's widely accepted in the community as a Sano shunt, although some publications refer to it as RV2PA conduit or
Oh, okay.
RV2PA. Yeah, and it's a shunt without a valve. Huh? It's just a Gortex tube, unlike other forms of belly or other forms of repair.
Yes, yes.
Any more questions? I don't know, Dr. Jamjoom was hoping to attend this activity. He asked me to send a link, but I'm not sure if he's with us today. Anyways, we'll try to expand the faculty in this teaching. I think it will be helpful to have different views and different levels of senior and junior surgeons participate in these activities. There is really, the more you learn, the more you discover that there are no one way or one correct way of doing things. There are different ways of doing things, and there are reasons for that. And hopefully, I believe Dr. Ahmed Alwi will follow me today.
Yes, sir.
Okay. Well, if there are no questions, I want to thank you all for this opportunity. And I have some feedback on the presentation. I believe in this routine and the time that both surgeons and trainees have. It's helpful to see videos, and it's helpful to see different things. If you guys want less videos and more literature or more didactic form teaching, please let me know. If this is okay with you, then we'll continue doing the same for future presentations. I can hear some feedback now, if that's helpful, because it will be helpful for me to understand your needs. This style is too boring, it's too long, or it's okay, or it's exciting, whatever. I would like to hear different views, and I promise you, I'm not going to remember who said what feedback, so don't worry. And it's a learning process for me as well as you. This new format of educational activity is still an ongoing learning process for me as well.
Actually, doctor, when you put the videos and you explained together, it was helpful. And your videos are clear, so it was easy for me as a junior.
Good. Well, just to make it
I agree.
They're not my videos, but I'm using them for their quality. They're excellent quality, and I have some videos that are unedited on my YouTube channel. They're a little bit long, but I also think long videos are helpful for people who are learning like the entire procedure. Dr. Uthman Al-Radi from King Abdulaziz University also has a very active YouTube channel with a lot of surgical videos that I think are very useful, especially for people who are interested in congenital heart disease. I personally like watching operative videos even at this stage. I think even 20 years from now, I will still enjoy watching a good operation and learning stuff from a video material. But just for the copyright reasons and these videos are from Dr. Hirashka's manual. And in the manual, there is an introductory video where he shows how these videos are made, and it's just fantastic.
Yeah.
I agree with Dr. Ayat feedback, because when I go and watch videos on the internet, there is some steps I don't quite understand, or I don't understand the principle behind it. So I find it really helpful that you are explaining the important steps and why we do what we do in each step. So yeah, I think we are happy to keep that going. That's my personal opinion. Thank you very much.
Thank you. دكتور أحمد موجود؟
I don't see him بالقائمة بس
أو
أنا راح أتواصل معه الحين.
في أحد من الفاكولتي؟
I don't see any.
That's okay.
Yeah.
I guess we're all busy, but that's good. I think we're good for time, and I'm sorry to يعني كده bore you with the 2 hours of presentation by the same person. I personally would probably fall asleep if the same person is talking to me for 2 hours. So thanks again, and until we meet next time, please feel free to communicate any feedback. And ماني فاكر هيثم مين اللي قلت لي هيتواصل معايا بخصوص البرزنتيشنز؟
عبد الملك حكلمه تمام واشوف معاه وهخليه يتواصل معاك مباشرة. حاجة ثانية دكتور، لأني دورت أنا على القناة تبعتك حقت اليوتيوب، لأني دخلت على تويتر أكاونت تبعك ما أنت زمان ما كتبت فيه.
I don't use Twitter. But my YouTube channel is public, but it's age restricted. So you have to be signed in when you لأنه it's 18 يعني محطوطة 18 plus بس for scientific reasons, not for anything else. And
no بس إنه تفضل.
يعني I think you have to لأنه I tried accessing it and I asked others to try to access it, so it's working. But I think you need to sign like إنه يعني you're above 18 ولا you have to be logged in to your account in order to see it.
Yeah, we just need the link or the name of the channel.
اكتب محمد شحاتة. Just type محمد شحاتة في السيرش. محمد MOH أيوة. I will put it in the group. How about that?
Yeah, thank you.
Okay, no problem. يلا, take care everyone. Until next time.
Thank you very much دكتور محمد. مع السلامة.
الله يعطيك العافية دكتور، شكرا جزيلا.
يعطيك العافية دكتور.
أعطوني بس دقيقتين شباب أتواصل مع دكتور علوي.
Sure.
1 minute only.
Of course, boss. شباب
أيوة.
اسمعوني؟ دكتور علوي يقول على الساعة تقريبا بعد نص ساعة بعد الصلاة مباشرة 3:25 3:35 يعني حول 3:30. فإذا تحبوا كل واحد يعني do whatever he wants ونرجع بعد نص ساعة.
أوكي.
أوكي شكرا.
في شيء ثاني